Hi, good day. I'm Leslie Babasa, a critical care nurse. I'm here to discuss all about an important tool that may improve patient care. If you are a nurse, you know that a comprehensive patient health assessment is an important first step in developing a plan to deliver the best patient care. Health assessments are a key part of a nurse's role and responsibilities. The assessment is a tool to learn about your patient's concerns, symptoms, and overall health. The FASTHUG mnemonic was proposed as a standardized approach to help ICU physicians ensure that all essential aspects of care for critically ill patients are met, which will not only help to reduce errors but also improve quality care. The origins of FASTHUG mnemonics are attributed to John Louis Vincent, who published an article in 2005. It was basically a self-directed CME exercise, and it was only supposed to be a mental checklist. About 4 years later, it became an important tool. So in 2009, Vincent and Hatton upgraded the mnemonic to fast hugs in bed, which included spontaneous breathing trial, bowel care, indwelling catheters, removal, and the escalation of antibiotics. And because it's becoming an ever increasing presence in the intensive care units, Chris Nixon modified it as fast hugs in bed. The multidisciplinary evidence-based strategy has been demonstrated to improve patients' outcomes. This is a useful tool to evaluate clients' every shift. The mnemonic provides standardized baseline data that ensures change to shift issues managed for safety, progression, and future planning. FastHub has the potential to dramatically improve collaboration among nurses and physicians and ultimately will not only help to reduce errors but improve patient care. Um, the mnemonic of FastHub is feeding, analgesia, sedation, thrombolytics, head of bed elevation, ulcer prophylaxis, glycemic control, indwelling catheters, nasogastric tubing, bowel movement, environment, and the escalation or escalation of antibiotics. Let's start with feeding. Nutritional support is critical in ill patients, prevents further metabolic deterioration and loss of lean body mass. Decrease in length of hospital stay, morbidity rate, and improvement in patients' outcomes have attracted and valued the use of nutritional support in the critically ill patients. Nutritional support serves to maintain or repeat lean body mass to support host defense mechanisms to avoid specific nutritional deficiencies, and in general to improve clinical outcome in a malnourished patient or in a risk of development malnourishment. Malnutrition is a common and serious problem in intensive care units. It has been associated with increased morbidity and mortality in critically ill patients. The increased incidence of complications like progression of infections, sacral ulcers related to malnutrition correlates with increased length of hospital stay and overall healthcare costs. There are two methods of feeding, enteral and parenteral feeding. So let's start with enteral feeding. Current guidelines recommends commensating enteral feeding early in the course of ICU stay, as this has been associated with a decrease in infections. Early enteral nutrition therapy has empirically demonstrated that initiating tube feedings within 24 to 48 hours of ICU admission or mechanical ventilation onset in critically ill patients with a functioning gut results in improved patient outcomes. Caloric target should be reached within 3 days, provided that caution is taken to avoid overfeeding and the resultant increase in risk of complications. Early feeding was also associated with a reduction in mortality in critically ill patients who are receiving a mechanical ventilation or who are hemodynamically unstable. They also concluded that the beneficial effect to early feeding was more evident in the sickest patients. Early nutrition Enteral nutrition may decrease risk of death by 30% to 35% according to a study by Khalid. Although early enteral nutrition is the preferred method of feeding critically ill patients, enteral nutrition alone often fails to supply adequate calories and nutrition to critically ill patients. So usually it is supplemented by parenteral nutrition. Parenteral nutrition provides liquid nutrients including carbohydrates, proteins, fats, vitamins, minerals, and electrolytes. The European guidelines from 2009 recommended that the practitioners consider adding parenteral nutrition to those patients not receiving adequate calories from enteral nutrition by the second day of ICU. Um, Parenteral nutrition is a provision of adequate nutrition in the face of gastrointestinal dysfunction. It is also useful in the face of fluid restriction since caloric density can be increased with the central venous catheter beyond that tolerated by the enteral route. The general indication for parenteral nutrition is the patient who cannot, will not, or should not eat enterally or orally, who cannot eat enough or to be fed adequately through a tube. Although parenteral feeding is a more complicated process with more complications, it is important for feeding patients when their gut does not absorb nutrients. Central vein cannulation is the most commonly used route. However, peripheral feeding is an acceptable alternative for short-term feeding. A single dedicated lumen should be used for administration of TPN. A nutritional assessment prior to commencement of TPN, the patient's nutritional requirements are assessed. Energy and nitrogen requirements can vary depending on age, sex, body composition, clinical status, and activity. In contrast, parenteral nutrition may be better secure the intended nutritional intake, but is also associated with more infections, complications, most likely due to hyperalimentation and hyperglycemia. Next in the FASTHUG mnemonic is analgesia. Patients in the ICU often requires analgesia to treat various sources of pain such as trauma, surgery, or other pre-existing medical conditions. Pain can readily be assessed with a pain scale, and the patient's level of pain should be checked routinely. Ideally, a patient will receive an amount of analgesic that's adequate so that the pain is not an issue, but not excessively, so that unwanted sedation and respiratory depressions are avoided, and to allow successful weaning from the ventilators. So, why should we give analgesics? Pain may influence immune function and coagulation and may increase sympathetic outflow, resulting in increased heart rate and myocardial oxygen demand. Sedation is indicated for the treatment of anxiety and agitation for similar reasons. Appropriate sedation is not only compassionate but is vital to patient care as agitation may contribute to ventilator desynchrony and altered day and night cycles. What are being used? Um, Opioids are the principal analgesics used in the ICU because of its potency. Concomitant mild sedatives and anxiolytic properties and their ability to be administered by multiple routes. Some of the opioids being used are fentanyl, oxycodone, morphine, meperidine, and acetaminophen. When should we give analgesics? Patients must be evaluated hourly to ensure appropriate response to therapeutic interventions so that healthcare providers can proactively act to relieve pain. And how do we assess pain? Ideally, pain assessments should include location, the characteristics, severity, onset, progression, duration, quality, radiation, alleviating and exacerbating factors and effects of previous therapies. There are a number of types of pain scales, one of which is the number rating scale, perhaps one of the most commonly used pain scales in the healthcare. The numerical rating scale is designed to be used by those over age of 9. If you use the numerical scale, you have the options to verbally rate your pain from 0 to 10 or to place a mark on the line indicating your level of pain. 0 indicates the absence of pain, while 10 represents the most intense pain possible. Another pain scale that we use is the Wong-Baker Faces Pain Scale. The Wong-Baker Faces Pain Scale combines pictures and numbers for pain ratings. It can be used in children over the age of 3 and in adults. 6 faces depicts different expressions ranging from happy to extremely upset. Each is assigned a numerical rating between 0 of smiling and 10 of crying. If you have pain, you can point a picture that represents the degree and intensity of your pain. Another one is the FLAC. FLAC stands for face, legs, activity, crying, and consolability. The FLAC pain scale was developed to help medical observers assess the level of pain in children who are too young to cooperate verbally. It can also be used in adults who are unable to communicate. The FLAC scale is based on observations with 0 to 2 points assigned for each of the 5 areas. The overall score is recorded as follows: 0 as relaxed, 1 to 3 as mild discomfort, 4 to 6 as moderate pain, and 7 to 10 as severe discomfort or pain. By recording the FLAC score periodically, healthcare providers can gain some sense of whether someone's pain is increasing or decreasing or stable. Another pain scale is what we call the CCPOT. Um, the CCPOT is a critical care pain observation tool. It's an observation of patients at rest at bedside. The patient must be observed at rest for at least 1 minute to obtain a baseline value of the CPOT. Should be observed during nociceptive procedures like turning, wound care, to detect any changes in the patient's behavior to pain. The patient should be evaluated before and at the peak effect of an analgesic agent to assess whether the treatment was effective or in relieving pain. The rating of the CCPOT, the patient should be attributed the highest score observed during the observation period. Its indicators are the facial expression, body movements, compliance with the ventilator. This is used when the patient is on mechanical ventilator. We have to observe if patient is coughing, activating the alarms, or if the alarms turns off spontaneously, and if in desynchrony. Vocalization is used in non-intubated patients that's able to talk. To observe the absence of sound in a normal tone if the patient is sighing or moaning or when the patient is crying out. Muscle tension is one of the indicators, which is also a very good indicator of pain. Considered the best one in the CCPOT, the best one in the CCPOT. When the patient is at rest, it is evaluated by performing a passive flexion and extension of the patient's arms. During turning, and the nurse can easily feel the patient's resistance when she is participating in the procedure. Let's go to the next mnemonic of FASTHUG, which is the S, which is the sedation. Sedative medications are commonly prescribed within the ICU environment primarily for the treatment of agitation and anxiety. Critically ill patients are commonly provided analgesia and sedation to prevent pain and anxiety, permit invasive procedures, to reduce stress and oxygen consumption, and improve synchrony and mechanical ventilation. Regular assessment of sedation and agitation are important for ensuring an adequate patient arousal. Consistent monitoring likely reduces oversedation, the use of unnecessary imaging to assess patient's neurological status. Um, there are depths of sedation that we could use: the minimal sedation, moderate sedation, and deep sedation. Usually, the minimal sedation are just for relief of anxiety. The moderate ones is responsive to tactile or verbal stimuli. The deep sedation is a purposeful, responsive to painful or repeated stimuli. Spontaneous ventilation or airway reflexes may not be maintained. However, cardiovascular function is still preserved. So usually we use also a method to check the depth of sedation. So we usually use the Glasgow scale. The Glasgow scale is the most common scoring system used to describe the level of consciousness. The Glasgow scale is a clinical scale used to reliably measure a person's level of consciousness in response to a defined stimuli. The GCS assesses a person's based on their ability to perform eye movements, speak, and move their body. These three behaviors make up the three elements of the scale: eye, verbal, and the motor response. We have another tool or method to check the depth of sedation. The Richmond Agitation Sedation Scale, or RAS, is an instrument designed to assess the level of alertness and agitated behavior in critically ill patients. Its purpose is simple and to guide sedation for therapy, improve communication regarding sedation and agitation among healthcare providers. The RAS is a 10-point scale ranging from -5 to +4. The lowest, +1, the classes will describe increasing levels of agitation. The lowest level of agitation starts with apprehension and anxiety and peaks at a combative and violent RAS level 0. Um, RAS level 0 is alert and calm. The full scale can be found at our graphics. The next mnemonic in the FASTHUG is the thromboprophylactics. Okay. Um, the thromboprophylactics helps to prevent the development of thrombosis in those considered at risk. Some people are at a higher risk for the formation of blood clots than others. Prolonged stay of intubated and bedridden patients in the ICU can lead to thromboembolism. The venous thrombolism, VTEs, including deep vein thrombosis and pulmonary embolism, are complications to patients in hospitalized and in intensive care units, and is associated with increased morbidity and mortality of these particular patients. VTE, or venous thromboembolism, is a condition that involves the formation of clots in the deep veins, particularly in the veins of the lower limb. This causes obstruction to blood flow, resulting in symptoms like pain, swelling, and discoloration. Primary prophylaxis is the one which is given to prevent occurrence of deep vein thrombosis, which include pharmacologic therapy like unfractioned heparin or low molecular weight heparin. When anticoagulation is contraindicated, mechanical thromboprophylaxis using either elastic compression stockings or intermittent pneumatic compression, or SCD, are being used. Almost all patients in the ICU should receive some form of thrombolytic prophylaxis. The next mnemonic we have is the head of bed. A semi-upright position in ventilated patients is recommended to prevent ventilator-associated pneumonia, and is one of the components in the ventilator bundle of care in an institution. VAP is the most common hospital-acquired infection in the ICU. Nosocomial pneumonia frequently occurs in patients receiving mechanical ventilation. The most commonly recognized cause of nosocomial pneumonia is the oropharyngeal colonization and subsequent aspiration of oropharyngeal contents. Elevation of the head of bed of intubated patients who can tolerate the semi-recumbent position is an effective, inexpensive method for reducing rates of aspiration pneumonia. Furthermore, elevation of the head of bed to 30 degrees has been shown to be of benefit in lowering intracranial pressure. Elevating the head of bed is thought to promote intracranial venous return and increase CSF drainage from the head, resulting in decreased ICP. So please ensure head of bed elevation unless it is contraindicated. Next we have is the ulcer prophylaxis. Stress ulcerations are very common in the ICU. In the ICU patients, some of which can cause hemorrhage. Many critically ill patients require prophylaxis for primary prevention of bleeding from stress ulceration or treatment for stress ulcer-related bleeding. Patients receiving mechanical ventilation in the ICU are most at risk for stress ulcers. And appropriate prophylactic medication should be administered. The most commonly used agents for this indication include histamine receptors antagonists and proton pump inhibitors. Example of the proton pump inhibitors or PPIs are the omeprazole, lansoprazole, esomeprazole, and pantoprazoles. Its mechanisms are usually enzyme systems which catalyze the exchange of catalyzes the hydrogen and potassiums. The histamine receptor antagonists are cimetidines, ranitidines, and famotidines. The mechanism of action of which these are H2 blockers, antihistamine agents that are used in the short-term treatment of an active duodenal ulcer and as prophylaxis in the long term. So the next mnemonic we have is the glycemic control. The use of intensive insulin therapy to maintain blood glucose at a level that did not exceed at 140 to 180 milligrams per deciliter substantially reduced mortality in the intensive care unit, in-hospital mortality, and morbidity among critically ill patients admitted to our ICUs. Critically ill patients who require intensive care for more than 5 days have 20% risk of death and substantial morbidity. Critical illness, polyneuropathy, and skeletal muscle wasting. It prolongs the needs for mechanical ventilation. Moreover, increased susceptibility to severe infections and failure of vital organs. Increased susceptibility to severe infections and failure of vital organs amplify the risk of adverse outcomes. If you have hyperglycemia and is untreated for long periods of time, you can damage your nerves, blood vessels, tissues, and organs. Damage to blood vessels can increase your risk of heart attack and stroke. And nerve damage may also lead to eye damage, kidney, and non-healing wounds. Hyperglycemia is a common complication of critical illness. Excuse me. Patients in intensive care unit with stress hyperglycemia have significantly higher mortality, 31% compared to patients with previously confirmed diabetes, 10%, or normal glycemia, 11.3%. Stress hyperglycemia is associated with increased risk of critical illness, polyneuropathy, and prolonged mechanical ventilation. Intensive monitoring and insulin therapy, according to the protocol, are an important part of treatment of critically ill patients. Next we have in the mnemonic is skincare treatment, which is, I think, one of the most important, one of the most important in here in the FASTHUG mnemonics. Pressure ulcers are a common complication in intensive care units who are sedated, ventilated, and or bedridden for a very long time. It is one of the challenges faced by all of us ICU nurses or all of us nurses. Risk factors, which includes friction and shear, immobility. This might be due to poor health, spinal cord injury, or any other causes. Incontinence, which makes the skin becomes more vulnerable with extended exposure to urine and stools. Lack of sensory perceptions, spinal cord injuries, neurological disorders, and other conditions can result in the loss of sensation. Poor nutrition and hydration. People need enough fluids, calories, proteins, vitamins, and minerals in their daily diets to maintain healthy skin and prevent the breakdown of tissues. Medical conditions affecting blood flow. Health problems that can affect blood flow, such as diabetes and vascular diseases, can increase the risk of tissue damage, such as bed sores. Knowing that the pressure ulcer is one of the challenges faced by the ICU nurses related to patients' need to stay at rest, to be under rigorous control or more complex therapy. With the techniques used in the unit, we all use is a Braden scale, monitoring and evaluating closer skin integrity, and allowing nurses to calculate the scoring average of the Braden scale and a greater incidence of ulcer in intern patients. The Braden scale is a standardized evidence-based assessment tool commonly used in healthcare to assess and document a patient's risk for developing pressure injuries. Each risk on the Braden scale is rated from 1 to 4 based on the patient's assessment findings. The lower the score, the higher the risk of developing a pressure injury. Additionally, customized nursing interventions are implemented based on the rating in each category. The higher the score, the more aggressive actions are taken to prevent or heal pressure injury. There are 4 stages of pressure ulcers. The stage one, pressure ulcers are areas for non-blanchable redness in intact skin. It has darker skin tones. An area of discoloration may indicate a stage 1 pressure ulcer. Usually, the treatment in this one is only to remove the pressure from the area and keep the affected area clean and dry to reduce tissue damage. Stage 2, pressure ulcers indicate partial thickness loss of dermis. Um, it may appear as an open area with a pink or red wound bed, as an intact or ruptured serum-filled blisters. Its treatment is almost the same as the stage 1. Relieve lang yung pressure and keep the area clean. Stage 3 of pressure ulcer are more severe than stage 2 because they had full thickness tissue loss. In a stage 3 pressure ulcer, subcutaneous fat may be visible, but underlying muscle bones or tendons remain covered. An ulcer in this stage may resemble a crater, and it may also smell bad. The treatment usually is kailangan mag-seek ng medical treatment if you have a stage 3 pressure ulcer. These sores need special attentions. Your doctor may prescribe antibiotic therapy and remove any dead tissue to promote healing and to prevent or treat infections. The stage 4 pressure ulcers are severe type of ulcers where full thickness tissue loss results in exposure of underlying muscle bones or tendons and ligaments. And in more severe cases, they can extend as far as down as the cartilage or the bone. These sores can be extremely painful. You can expect to see drainage, dead skin tissues, muscles, and sometimes bone. the skin may turn black and exhibit common signs of infections. Usually, the treatment for this is to be taken to the hospital, and usually the doctors will recommend surgery for debridement. There are two also extra stages of pressure ulcer, which is the unstageable ulcers that are full thickness tissue loss where the ulcer cannot be staged because of eschar or slough. Because unstageable ulcers indicate full thickness tissues loss that also a severe type of ulcers. Another one is the suspected deep tissue injury. Pressure ulcers often appear as purplish or bluish looking tissue or as a blood-filled blisters. In darker skinned people, deep tissue injury may appear as a thin blister over a deeply pigmented area. Bed sores can be prevented by inspecting the skin for areas of redness, which is the first sign of skin breakdown, every day with particular attention to bony prominences. The next one we have the mnemonic is the indwelling catheters. This does not only pertain to the Foley cath, but every catheters there is. Intravascular catheters are indispensable in modern-day medical practice, particularly in the ICUs. Although such catheters provide necessary vascular access, their use puts patients on risk for local and systemic infections and complications, um, including local site infections, CRBSI or catheter-related bloodstream infection, septic thrombophlebitis, endocarditis, and other metastatic infections. For short-term peripheral catheters, good hand hygiene before catheter insertion or maintenance, combined with proper aseptic technique during catheter manipulation, provides protection against infection. To prevent CRBSI, usually antibiotic lock prophylaxis has been attempted by flushing and filling the lumen of the catheter with antibiotic solutions and leaving the solution to dwell in the lumen of the catheter. Transparent dressings reliably secure the device, permit continuous visual inspection of the catheter site, permits patients to bathe and shower without saturating and dressing, and requires less frequent changes than to standard gauze and tape dressings that's being used. The recommendations here are educations and trainings to for the healthcare providers to insert and maintain catheters, using maximal sterile barrier precautions during central venous catheter insertions, using 2% chlorhex preparation for skin antiseptics. Usually use povidone iodine or 2% chlorhexidine. Using antiseptic or antibiotic impregnated short-term central venous catheters if the rate of infection is high, despite adherence to our other strategies. It is the utmost importance of the frequency of assessment with all of the indwelling catheters. Frequency is dependent on the protocol of your institution. Next we have is the nasogastric tube. Next we have is the nasogastric tube. Enteral nutrition is the preferred feeding method for those patients with normal functioning gastrointestinal tracts but with inability to ingest adequate nutrition solely by mouth. Patients and their caregivers are important team players in the effective management of nasogastric tube feeding. Nasogastric tube feeding recommendations are focused on implementation of feeding, monitoring, and management of nasogastric tube feeding, um, monitoring and management of gastrointestinal tolerance. Gastric residual volumes or GRV should be checked 4 to 8 hours in continuously feeding patients and before each intermittent feeding. GRV greater than 200 should prompt careful bedside evaluation and initiation of appropriate feeding method and feeding volume. There are also complications in NGT feedings, which are feeding intolerance, diarrhea, and aspiration pneumonia. In aspiration pneumonia, you should monitor the patient for signs and symptoms of aspiration pneumonia, including unexplained fever spikes, changes in sputum color or consistency, change in breath sounds, worsening of oxygenation, and setbacks in ventilator weanings. Importantly, don't forget to always check the placement of the tube. Again, dependent of the it is also it is dependent on the protocol of your institution. In our institution, the final positioning confirmation is with an X-rays. The next mnemonic is bowel movement or bowel care. Diarrhea can lead to electrolyte imbalances, dehydration, or hemorrhoidal irritation with resultant anemia. Constipation can lead to patient discomfort and feeding intolerance. Our responsibility should always be to observe the abdomen and look for abdominal distensions, auscultate for the presence of bowel sounds if present, and note the pitch. Palpate for the tenderness, tightness, rigidity of the abdomen. Document passing of flatus, quantity, and nature. The next one with the FASTHUG mnemonic is the environment, which is solely for observation of the temperature control, appropriate surroundings, and patient's precautions. If the patient is in on aspiration, contact and droplet precautions, or airborne precautions. Last but not the least is the escalation of antibiotics. Appropriate antimicrobial therapy is essential to ensuring positive patient outcomes. Inappropriate or suboptimal utilization of antibiotics can lead to increased length of stay, multi-drug resistant infections, and mortality. Critically ill intensive care patients, particularly those with severe sepsis and septic shocks, are at risk of antibiotic failure and secondary infections associated with incorrect antibiotic use. Daily evaluation of signs and symptoms of infection and narrowing of antibiotic therapy when feasible. Providers can streamline the treatment of common intensive care unit infections, thus improve patient outcomes and minimizes the pressure on emerging antibiotic resistance. De-escalation or discontinuation of one or more components of combination empirical therapy uh, or change from a broad spectrum to a narrower spectrum antimicrobial, it is most commonly recommended in the ICU patients who is treated with broad spectrum antibiotics as a strategy to reduce antimicrobial pressure of empirical broad spectrum therapy and prevent antimicrobial resistance. To conclude, we can say that FastHug is an addition into being a tool to evaluate assisting quality and assure patients that their needs will be fulfilled while they remain in the ICU. May be considered to boost and overcome to new challenges. Along with the checklist, a reduction of shortcomings was observed. FastHug encourages teamwork and help in improving the quality of care received. It ensures safe and effective efficient care. It provides structure to important ICU intervention in an effort to reduce omission and increase compliance with evidence-based practices to improve outcomes of effective nursing care. That's the end of my slides. Thank you for listening, and I hope you've learned something um, from my presentation. Thank you and good day.